The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening, everyone, and a warm welcome to tonight's RX Question Lab workshop. It's fantastic to have all of you with us as we delve into the complexities of endocrinology. So we're going to get into hormones tonight, key area of knowledge for any aspiring physician and a significant component of USMLE Step 1. My name is Jeff Downing, and I am delighted to be your host tonight. We're going to dive deep into board style questions. I'm going to try to illuminate some of the core concepts and provide you with some tools and strategies that you can use to answer these items, answer them tonight, as well as answer them correctly on test day. So with that, I want to introduce my co-host this evening, Dr. Abraham Titus. Abraham, would you like to introduce yourself to the crowd?
Thank you, Jeff. My name is Abraham Titus. I'm one of the Hematology Oncology Fellows at University of South Alabama. I've been a tutor with RX for about 5 years now, since before residency, and I've helped many students such as yourself through Step 1, Step 2, and Step 3, and help them achieve their goals on Step. So I'm happy to be here and go through some tough endocrinology questions together.
First off, we are obviously here at USMLE-Rx. We're the team that brings you everything within the Rx system, and started by Dr. Tao Li, who's the one of the senior editors for the First Aid series. So what we want to do tonight is we're going to take you through a series of questions. Part of it's going to be about content, right? Part of it is going to be about understanding, well, what's happening with this patient or what's happening in this particular situation. But we also want to help you focus on sharpening some of your test taking skills. And so typically what we do is we step you through our suggested approach to answering questions. So anyway, as we go through this, that's what we're going to do. We just want you to have a methodology, right? We want you to have an approach so that you can do well on your self-assessments, on your CBSEs, whatever you're doing, and then eventually on STEP. Okay, so with that on the way, let's go ahead, get started. Question number 1. What you're going to see when I open up the question? Well, there's something missing, right? Missing the answer choices, and that is by design. So we've got a couple of things that we suggest you incorporate as you go through these questions. First is we say cover up the answer choices. Part of the reason here is that you don't want to distract yourself or get distracted by an answer choice containing something that has troubled you in the past or that you find confusing, or maybe you've never even seen before. What we want you to do is cover up those answer choices and focus on the lead-in, which is the question part of the QID, right? So in this case, the lead-in is, which of the following hormones uses a signaling pathway that is most similar to that of the studied hormone? Okay, so by reading that first, as opposed to reading the vignette first, now you kind of know what the question is about, as well as what kind of information you should be looking for. Again, we want you to be efficient, and you know that on some of these questions, the vignettes can be really long. In this particular case, we're starting off with a short one. So the idea though is that we want you to really be training your focus on the key details as you go through it. Okay, so we've read the lead-in, and now we're going to read the vignette. A research team is investigating the signaling pathway induced by the binding of a hormone to its extracellular receptor. The studied hormone is made by the liver in response to growth hormone release by the anterior pituitary gland. So the question again, which of the following hormones uses a signaling pathway that is most similar to that of the studied hormone? I'm going to ask everyone here to go down to the question box and let us know how many steps you think it is going to take in order to solve this. Okay, and while you do that, I am going to pass the mic to Abraham.
All right, thank you, Jeff. So as Jeff mentioned, it's very important to read the lead-in question. Sometimes, unlike this question, you'll have a very big vignette, and it's very easy to get confused about what you're looking for. So understanding that the point of the question is and what the main lead-in, what you're looking for, is very important. So you read that in the beginning, read the vignette, and then read it once again at the end. That pattern is shown time and time again to make sure you keep your focus and don't let yourself get distracted with all the extra things I mentioned in the vignette. So let's highlight some keywords here. So what are important from this question? Right, so this is one of those questions where it's like a research team. You're going to get every once in a while, you're going to run into these. Right, this is step one, really testing some of the basic sciences and understanding the concepts. We all like clinical medicine. We all like to stick with our clinical knowledge, but we do need to work on our basic science knowledge as well. And that's what this question is. You're going to get sometimes like some guys working in his garage and working on this new experiment, something like that. So think about it and don't get too distracted by the fact that it's an experiment, and just understand what they're asking here. So you're looking at a hormone that's made by the liver in response to growth hormone released by the anterior pituitary. What hormone do you think they're talking about? That should be going through your mind. All right, you guys can put it on the answer on the comments if you'd like, but think about that. Now, they're going to give you options here, and based on that hormone, you want to think what acts similar to that. Think about mechanisms of actions of hormones, the difference between the different types of hormones, and let's go over that. All right, let's take a look at the options, and let's try to break down what this is. Right, so we got 5 options here. They're all different types of hormones and different proteins that are present in our body. Let's start with option A, ACTH. Option B, brain natriuretic peptide, also known as BNP. Option C, cortisol. Or option D, erythropoietin. Or option E, insulin. Now, I'm not going to give you guys more clues than that. That's the point. So your goal should be, just from reading this question, I want you guys to think about it. We'll talk about why I think certain things are correct and certain things are incorrect, and what the question is really trying to get you to think about after we get the answer. So let's go through this again. All right, and I think the poll is up right now. You guys should be able to click just like the first question. Go ahead and vote for which option do you think is the correct answer.
Okay, so yes, the poll is launched, and looks like the answer letter for the last one didn't show up, but you don't need to worry about that. Just select the choice that makes sense to you. Give everybody a chance to cast their vote. Again, remember on on test day, you don't have a whole lot of time to get through the lead-in, the vignette, try to come up with your answer. Everything kind of has to be done under 90 seconds, right? So part of the idea behind our methodology is to take these questions on methodically, right? And so you're not having to think about your process. Okay, 3/4 of you have voted, so I'm going to close the poll, and let's take a look at the results. So looks like 40% of you went with insulin, whereas cortisol and erythropoietin tied for second place, with ACTH right on their heels there with 15%. So kind of an interesting mix. Let's go ahead and hide the results and reveal the answer. And the answer is answer choice E, insulin. So well done, everybody. That is a great start for tonight. If you didn't get it right, that's okay. We're going to work through it here as Abraham walks you through that explanation.
Awesome job, guys. And again, don't feel bad if you didn't get this question right. I picked some tough questions today. I really wanted to challenge you guys as much as possible. And really, endocrinology, I feel that there are some really easy concepts, but there are some really challenging concepts. And your goal during these times is to really master these challenging concepts. So what is this drug we're talking about, or this hormone we're talking about. There's this hormone that's released by the anterior pituitary gland called growth hormone. Now, growth hormone's job is to tell the liver to make something called insulin-like growth factor, which is what does the signaling. It works on something called tyrosine kinase and does its action accordingly, right? Whatever it may be, which we can talk about. But the idea here is that understanding that growth hormone works with insulin-like growth factor, and insulin-like growth factor, the name gives it away, it's insulin-like. The reason why they call it that is because it acts on tyrosine kinase receptors to have its action, as opposed to some of the other options, right? If we look at erythropoietin, cortisol, BNP, ACTH, none of them act on tyrosine kinase. And cortisol is a steroid hormone, right? It acts intracellularly. That's a whole different mechanism than my insulin-like growth factor. And that's what really they're trying to get at here. Being able to separate that and understand that is the key to this question. And if you look at the other options as well, where do these hormones come from? That's the other trick, right? ACTH comes from, it comes from the pituitary gland. The BNP, where does that come from? That comes from the heart. Cortisol comes from the adrenal cortex, and erythropoietin comes from the kidney. And that's also kind of a concept they want you to understand. But again, the main concept from this is they're talking about insulin-like growth factor coming from the liver, which is most similar to insulin, just like the name suggests.
Okay, excellent. Thank you, Abraham. So some good, a good hormonal foundational question here. A little bit, this is not the typical type of question you're going to see there on, in step one, but this is something that you're, the kind of question you are likely going to see in this particular category. So with that, let's go ahead and take a look at question number 2. Okay, so again, we have covered up all the answer choices, and we are going to read the lead-in. Serum concentration of which of the following hormones is most likely to be decreased in this patient? Okay, so again, it's another trying to find the right hormone question, and you're also going to be thinking about it in terms of serum concentration. So this is again very helpful. You can see why reading that lead in first is going to help kind of keep you focused as you go through the vignette. So let's read that now. A 7-year-old boy is brought to the clinic because he began growing hair on his upper lip and developed a deepening voice about 1 month ago. His growth and development had been previously normal. His father went through puberty at a young age and was shaving by the age of 11. On physical examination, the patient has some dark hair on his upper lip and sparse chest hair. Workup indicates premature virilization secondary to increased androgen concentrations. So again, serum concentration of which of the following hormones is most likely to be decreased in this patient? Head on down to the question box. Let us know how many steps you think it's going to take to answer this one while I pass it over to Abraham.
All right, so this is definitely much more of a clinical question. And again, like Jeff said, these are the kind of questions you're likely to see. Although there is a small portion of basic science questions you need to know, this is the majority of it. So let's focus on what is the most important stuff here. So let's go through our highlighting method here. Let's highlight some of the most important words here. And let's talk about what the point of this question is, right? So you have a 7-year-old boy. I like to always highlight age just to kind of have a mental visual presentation of the patient and understanding what we're dealing with. And has hair in his upper lip and deepening of his voice for about a month. Okay, so certain things should be coming up into your mind at this point. We talk about his father, okay, sure. But really what's key here is that the workup indicates premature virilization secondary to increased androgen concentrations. Now, why would that happen? And where do these androgens come from? So you got to think about these things. Now, back to the lead-in. Serum concentrations of which of the following hormones is most likely to be decreased in the patient? So you're going to look through the options here, but decrease is the most important thing here. Okay, so let's take a look at the options. All right, so we have, again, 5 options again. And a lot of these things, don't be intimidated if you don't recognize some of these options right away, but it's important to understand generally where these things fit into our concept and where in endocrinology you should be thinking about this? What chapter? So option A, 17 alpha hydroxyprogesterone. Option B, androstenedione. Option C, cortisol. Option D, dihydrotestosterone or DHT. And option E, pregnenolone. Again, these are different hormones that are present and are affected in this situation. The key to this question is trying to think of a diagnosis. And if you don't come up with an exact diagnosis, still generally understanding what kind of condition he has. And then trying to figure out, based on that, which of the serum hormones will be low. All right, let's see how you guys approach this question here. The poll is up.
Okay, everybody, go ahead and take your best shot. Select that that hormone that you think is going to be decreased in this 7-year-old boy. And we do, suggest that, again, endocrine's got a lot of this, kind of stuff, and sometimes, there may be areas here where you struggle, and that's okay. We hopefully with Question Lab and study, you can determine where some of your gaps are or some of the areas where you might be, struggling. But if you hit a question like this that you're just have no idea about, or you're like, I can't square it away. Don't get stuck. Just take a shot. You're not going to get penalized for an incorrect answer on test day. So just make sure you never leave an item left unanswered. Okay, let's see. Oh, 80% of you have answered. So I'm going to close the poll. And very interesting. So we've got pretty much a virtual tie. Just a slight edge for cortisol, but we also had just about as many folks going for answer choice A, 17 alpha hydroxyprogesterone. But answer choices D and B also got double digits. So anyway, interesting results here. Interesting spread. So let's go ahead, hide the results, and reveal the answer. And the answer is answer choice C, cortisol. So again, since that was the leading vote getter, even if just edged out answer choice A, we're going to consider it a win for the crowd. So well done, everybody. But obviously, this was a little tricky. So if you didn't get it right, that's okay. This is the time to miss it, right? So let's hand it over to Abraham so he can walk us through it.
All right, I wasn't lying about that. So these are some tricky questions. All right, and good job, guys, on getting that correct. Even if you did not get it correct, don't worry about it. This is definitely a big chapter, and endocrine, especially when it comes to the adrenal gland, is super high yield. And when understanding these hormones, and I'm sure you guys have seen this zona glomerulosa fasciculata reticularis before, don't be overwhelmed by all these different hormones and all these steps. Just have to understand the general concept of it and generally what each of these areas of the adrenal cortex is doing and what hormones are creating. So let's kind of quickly walk through this. I know we don't have a whole lot of time, but I want to make sure you guys have a good grasp of the adrenal cortex. So you have everything starting with cortisol, and the way I imagine this is that imagine water flowing down the pathway. So starting from cortisol, making its way all the way to testosterone at the end there. You can make aldosterone in the first area, you can make cortisol in the second area, and you can make testosterone at the end. Now, there's a bigger picture here, perfect. Now, you have three main hormones you care about here. You have your 17 hydroxylase, you have your 21, and you have your 11. So the 17 is the ones that go to the right, 21 is the first one that brings it down, and then 11 is the second one that brings it down. So quickly in this question, the patient we know has virilization and has increased hair growth. So we know that they have lots of androgens. So you have to be able to make androgens, so testosterone and stuff. So 17 cannot be deficient. It's got to either be 21 or 11. They don't give us other information to figure out which one it is, but it doesn't matter. The key to this question is that as long as I know this is a congenital adrenal hyperplasia, that's this whole criteria. All three are all considered a congenital adrenal hyperplasias. Cortisol is low. So if I want you to take away anything from this question, cortisol is low in all three of my congenital adrenal hyperplasias. Because it doesn't matter if I cut it off at the 17, well, I'm not able to go right and make cortisol. If I cut it off at 21, I can't go from 17 hydroxyprogesterone to 11 deoxycortisol. If I cut it off at 11, then the next step is cut off. So no matter what, I don't make cortisol. So low cortisol is seen in all three of my congenital adrenal hyperplasias. Now, one extra thing I'll just throw in there just for completion's sake. Why do we call it a congenital adrenal hyperplasia when it sounds like we're cutting off things and shouldn't it be a hypoplasia? Well, cortisol, like most things in endocrine, has a negative feedback system. Cortisol is what negatively feedback and tells ACTH not to release, tells your pituitary gland not to release more ACTH. So when I'm deficient in this cortisol, my body is going to try to make more cortisol, and it's going to try to release more ACTH, which is going to drive the entire system to work even harder. And that's what creates that hyperplasia going on. Okay, so this is a tough question, and it's worded in a way to trap you to go for the 17 or the 21, but the key here is what is decreased, and no matter what, cortisol is decreased in all my congenital adrenal hyperplasias. So going back to the question here, looking at the options, right? So option A, 17 hydroxyprogesterone. That if that was deficient, I would not be able to make any androgens in the first place. So this person, instead of a male having virilization and masculine effects like increased hair growth, deepening of the voice, you would have a female presentation that's actually an XY, for example. So it's a male who is not developing male characteristics because you're not having those androgens being made. Look at the other options. Option B, that's the same idea. If you're not making androgens, and draw, like every time I hear all these words that I don't know what they are, if I see the word andro in it, I'm assuming it's an androgen, right? So androsterone is just a precursor to testosterone. Option D is DHT. That's an advanced testosterone. That's another form of testosterone. And then pregnenolone, that again is one of the early steps in the zona glomerulosa, and that is again will not be low because that's not what the problem is at. In this situation, cortisol is low. Again, tough question. Good job in answering it, guys. And keep studying and really go over this chart here. That'll save you a lot of points.
Excellent. That's a great little mini lecture there. Thank you, Abraham. Good stuff that everyone here can take to the bank. So nice work. So time for a quick stretch break. Obviously, all you med students and graduates out there, we know the challenges of navigating the vast sea of medical knowledge, and it's not just about passing step 1 or passing step 2 CK. It's really about excelling and making sure that you're ready for this journey. So obviously if there was a tool that was designed specifically to make it more manageable, efficient, and successful, that would be great. And that's what we aim to do with USMLE-Rx. So USMLE-Rx is crafted by ScholarRx. It's really your personal navigator through the complexities of med ed. It's a comprehensive tool. It's designed to adapt to your unique learning needs, offering our QMax question bank, our flash facts, our in-depth video explanations through Express Videos, and RX Bricks. So, imagine a resource where thousands of high-yield questions allow you to test and refine your knowledge with adaptive flashcards to help focus your study efforts on areas that need improvement, while clear and concise video explanations make even complex topics like endocrine understandable. And then obviously with RX Bricks, you've got small digestible learning modules that'll help you build a solid foundation of medical knowledge brick by brick. Each of these bricks is designed to really help you understand and retain key concepts and make your study sessions more productive and more engaging. So we always want you to envision walking into the Prometric Center or walking into the exam room with confidence, armed with the knowledge and the skills honed by RX. So again, if you're ready to elevate your medical studies, consider us. We have a special offer on the site right now to help you start your journey towards mastering medical studies with confidence and with the bricks and QMax. Again, you're building a solid foundation for your future in medicine. So again, study smarter, not harder. Your pathway to the residency of your dreams can begin right now. Okay, stretch break over. Let's go ahead and get into question number 3. Now, I am going to warn you. Questions 1 and 2, they're tough, right? But they were kind of warm-ups. Now we're getting into the good stuff. So I want you to focus even a little bit harder. So again, what I'm going to do is I've got all of those answer choices covered up. You should just focus on the lead in. And again, it's about hormone levels. So which of the following hormone levels is most likely significantly decreased in this patient? Okay, kind of, a similar type of question that you're seeing here, right? So with that, again, now you kind of know what to look for. So let's read the vignette. A 29-year-old woman comes to her physician because of increasing fatigue, dizziness, irregular menses, and cold intolerance. 1 month ago, she underwent an uncomplicated transsphenoidal resection of a pituitary prolactinoma. Blood pressure is 96/60. Physical examination is unremarkable. Serum studies show a glucose level of 65 and decreased triiodothyronine and thyroxine. So, again, which of the following hormone levels is most likely significantly decreased in this patient? Head on down to the question box. Let me know how many steps you think it's going to take to solve this one as I pass it over to Abraham.
All right. Yep. Jeff already warned you guys. I picked some tough ones this time because I really feel that getting good and really understanding these tough questions makes everything else much easier. So let's break down this question and let's go through what's the key words here. So we have a 29-year-old woman, just like I talked before. You want to have a visual understanding and age for a patient, especially in endocrinology. Came in, fatigue, dizziness, okay. Irregular menses and cold intolerance. Okay, that should ring some bells for you guys. What does that mean to you? And then she had recent surgery, a transsphenoidal resection of the pituitary prolactinoma. So she had prolactinoma resection. Now her blood pressure is on the low side, 96/60. Otherwise, physical exam's okay. So, and we see her glucose level running a little bit on the low side at 65, and her T3, which is the triiodine, and thyroxine, which is T4. So T3 and T4 are both low. So it looks like a lot going on, but really there's one key thing that's important here. And our question is, which of the following hormone levels is likely significantly decreased in this patient? All right, let's look at the options here and really have a good understanding of what's happening here. So let's look at options. So A is adrenocorticotropin, which is pretty much ACTH. Option B, corticotropin releasing hormone, also known as CRH. Option C, glucagon. Option D, parathyroid hormone, PTH. And option E, thyrotropin releasing hormone, TRH. So you got a lot of releasing, stimulating, all these different hormones. And the key here is understanding the patient's clinical presentation and their recent procedure. Connect the dots and you'll be able to get to the answer. All right, so take your time, think about this one, look at the options, and hope you guys are able to pick the correct answer.
Okay, everybody, the poll has been launched. So yes, once again, you're trying to figure out which hormone level is significantly decreased in this 29-year-old female patient. And as as Abraham pointed out, you're going to have these questions. This, I think this vignette has a lot of it's kind of condensed with information, right? You're going to have some vignettes on test day that are really long, but sometimes they're just they're a little bloated, but they don't necessarily just not that they have a bunch of red herrings, but sometimes it's just the item writers are just a little more florid. But you are going to have some of these where it's like you've got a lot of very important pieces of data that you need to be able to work your way through in order to get to the answer. So in any case, that there's this is good practice. If especially if I know we've got some M1s here tonight, and we've got some M2s that may be getting serious. So it's this is definitely great practice. Okay, looks like a little over 2/3 of you voted, so I'm going to go ahead and get ready to close the poll. Okay, and let me share the results. So pretty strong consensus for answer choice E, thyrotropin releasing hormone. Corticotropin releasing hormone came in second, adrenocorticotropin right on its tail. So crowd feels a little bit stronger about this particular one. So let's go ahead and see how we did. So I'm going to hide the results and reveal the answer. And the answer is answer choice A, adrenocorticotropin. So the third place answer was the correct one. So since less than a fifth of you answered that, means we've got a knowledge gap that we need to close. So I'm going to pass it over to Abraham to walk us through it.
All right, so I finally got you guys on this one. This was a tough one, and I warned you guys ahead of time, but it really isn't as hard as it seems, right? It seems like a tough question. Everybody's caught on the cold intolerance and menses, thyroid function being low, and everybody wants to say this person has hypothyroidism. Well, I'm not denying that the patient doesn't have hypothyroidism, but where does thyrotropin releasing hormone come from? Thyrotropin releasing hormone is secreted by the hypothalamus, right? All the releasing hormones come from the hypothalamus. Corticotropin releasing hormone, gonadotropin releasing hormone, thyrotropin releasing hormone. All the releasing hormones come from the hypothalamus. This person did not have brain surgery. They had pituitary gland surgery. Slightly different. Pituitary gland surgery can put you at resection for damage of the pituitary gland. That's the key. They wouldn't put that in the question if they didn't want you to use that. The key here is that the patient had pituitary surgery, then presented with cold intolerance, had irregular menses, blood pressure low, and glucose low. So it's not just hypothyroidism. They have other things going on as well. You need to connect the dots here. That's what I was trying to really hint at here with the big clue here. So let's go through this here. So what happens when you have a pituitary gland surgery? You can damage the pituitary gland. What hormones come from the pituitary gland? All my stimulating hormones. So if the option E was thyroid stimulating hormone, you guys would be 100% correct. But it's a releasing hormone, and releasing hormones are secreted from the hypothalamus. Same with option B, corticotropin releasing hormone comes from the hypothalamus. Adrenocorticotropin, I gave you guys a clue, it's ACTH. ACTH comes from the pituitary gland, and that is what's exactly damaged in this question. This person has pituitary injury or hypopituitarism. This is very common in pituitary surgeries, highly tested, and that's what I really wanted to make sure you guys focus on this. Don't always fall for the trap for if I see cold intolerance, it's always hypothyroidism. Sure, but is there something else going on? The irregular menses could be your FSH and LH messing up. Could they have your ACTH messing up that's messing with the blood pressure? Because you need ACTH to make aldosterone. In endocrine, it's about seeing the big picture and not focusing on just one symptom and one. Cold intolerance equals hypothyroid is a good thought, but don't close yourself off and ignore the other keys in this question. Okay, so don't be too hard on yourselves there. Very high yield question, and I'm sure next time you guys see somebody undergoing a pituitary resection, you think about pituitary disorders, not hypothalamic injury.
Okay, so again, that's a great tip, and hopefully you can lock in on that. Put that one in your kind of your Q bank memory so that you can make that connection on an upcoming test or exam. Okay, everyone, this is the end of our journey here. Question number 4. So again, we're going to have a raffle here at the end of tonight's event. So make sure you stick around. So what I'm going to do is we're going to open up our final question of the night. And you can see we've got a lot here. This again, we're just warning you in advance. This is another challenging one here from USMLE-Rx. So we're going to start by reading the lead-in. Which of the following is the most likely diagnosis? So, that's your classic step one question. So again, we know that we're going to be going through the vignette to figure out what's happening with this this patient, what the most likely diagnosis is. Okay, so let's go ahead and read that vignette. A 37-year-old woman comes to her primary care physician because of 2-week history of frequent urination. She reports voiding large volumes of urine 7 to 8 times per day. There is no hematuria. Medical history includes diabetes mellitus, treated with metformin, and schizoaffective disorder, treated with paliperidone and lithium. Vital signs are normal. Serum studies show a sodium concentration of 130 and a glucose concentration of 102. Urine osmolality is 75. Serum lithium levels show 1.2. So again, which of the following is the most likely diagnosis? Think about that as I pass the mic to Abraham.
All right, so we highlighted some keywords here. Again, this is another tough question, so I don't want you guys, just like the last question, one thing doesn't always mean it's the correct answer, right? So buzzwords are important, but look at the full picture. All right, so you have a 37-year-old female, 2 weeks history of frequent urination. So she's urinating a lot, large volumes, 8 times per day, fine. She's got diabetes, and that's fine, but she also has schizoaffective disorder, and she's on 2 very important medications, paliperidone, which is an antipsychotic, and lithium. Now, her sodium concentration is 130, which is on the lower end, and glucose of 102, fine. Urine osmolality is 75. Now, this is something that a lot of students ask about. If I'm like on an exam and I want to make sure I'm not messing up my lab values, I'll have my lab values open on the side. If I look at the urine osmolality, normal value is a huge range. It's from 50 to 1200. Now, that's where logic comes in, right? You want to think about it. If it's closer to the 50, it's very dilute urine. If it's closer to the 1000, 1200 range, it's very concentrated urine. So although this is within normal ranges, you have to remember it's a dilute range urine osmolality. Serum lithium levels are 1.2. And which of the following is the most likely diagnosis? All right, let's look at the options here. So you have a patient who is urinating a lot. She's on a couple of medications that are important. Her sodium is low, and she's got dilute urine, and her lithium level is 1.2. Now, I go through these options here. Option A, central diabetes insipidus. Option B, hyperglycemic osmotic diuresis. Option C, low total body sodium. Option D, nephrogenic diabetes insipidus. Or option E, psychogenic polydipsia. Now, tricky question here, but I want you to think about it, right? You have 3 really good differentials in the options here, and you should use the full knowledge of the question to get to the answer here. All right. So take your time, think about it, and pick the correct answer.
Okay, everybody, we're here to close out strong, right? So hopefully you've been able to take some of the tips you've learned tonight, as well as some of the clues, and we'll see how you do here on our final question of the night. Good session tonight. Glad to see all of you here in the crowd. I know some of you stayed up late or got up really early. So as always, I'm going to be asking you guys to let me know where you're studying. But first, let's focus on the question. Let's see how the crowd does here on the closer. Okay, almost 2/3 of you have voted. I know this is a tough one. Don't, again, it's and it's okay. Some of you may not even may not have even gone through your endocrine block, right? So that's okay. If you're not feeling it, just take a swing, take a guess. That's okay. It's okay on test day. It's okay on question lab. Okay, so we've got most of you have now voted. So let's go ahead and close the poll. Let's take a look. So, boy, out of all of the questions that we've had tonight, question number 4, our final question, is the one where one answer choice is pulled in the most votes. So, yeah, almost half of you went with nephrogenic diabetes insipidus. About a quarter of you went with psychogenic polydipsia, and 17% with central diabetes insipidus. Okay, so interesting spread. Let's hide the results and reveal the answer. And the answer to question number 4 is answer choice E, psychogenic polydipsia. Okay, we warned you. We told you the second half of tonight was going to be tough. Threw a couple of challenging curveballs at you. So it's okay to get mad at us, but we knew that these were some things that were going to help you down the line. So with that in mind, I'm going to pass it over to Abraham to guide us through this one.
All right. Yeah, I will take the blame on this one. It is a tough question and it is an important question. I did tell you guys there's 3 good differentials and those were the top 3 choices. Option A, option D, and option E are all 3 good differentials. First of all, let's rule out why it's not B or C, right? B, hyperglycemic osmotic diuresis. Her glucose is only 102, right? So it's not high enough to worry about hyperglycemic being an issue. And low total body sodium wouldn't be the reason usually when we deal with sodium. Whenever we deal with sodium issues, it's all about fluid concentrations and messing with that, right? The total sodium isn't really what matters in this situation. All right, so let's think about what's going on here, right? I saw all of you guys, or most of you guys, went with nephrogenic diabetes insipidus, and that's a great answer, and it's probably the second best answer in this situation because of lithium, right? That's the key association you guys learned, and I'm glad you guys be able to recognize that, and you want to build on that knowledge, right? So that knowledge of understanding lithium causes nephrogenic diabetes insipidus is very important. What is nephrogenic diabetes insipidus? When the kidney does not respond to ADH and it just urinates. So it sounds like what's going on here. The patient is not able to concentrate her urine, so urine is very low osmolality, which I agree with, and the patient is having lots of urine, right? So frequent urination, high volume urine, good. So that fits. Same thing with central diabetes insipidus. That also would fit, right? There's no indication that she has some kind of damage to the brain that would cause central diabetes insipidus. So maybe that's a little lower on the differential, and with her being on lithium, then nephrogenic could be higher. But why is the answer psychogenic polydipsia? That's where the trap is here. This is the kind of the higher level question. That's going to take you to that 99 percentile, the top scoring thought process. And that's what I want you guys to learn. If you guys can learn that, the rest of it becomes easy. The reason why it's psychogenic polydipsia is the serum sodium. Think about this, right? If I have a nephrogenic or central diabetes insipidus, I'm constantly urinating out free water. So what's going to happen to my sodium concentration in my body? It's going to go up. I'm going to become hypernatremic. Hypernatremia is a result of diabetes insipidus. So when I have hyponatremia with a dilute urine and lots of urine, the person is just drinking a lot of water. And the person having schizoaffective disorder is the hint of that. So this is kind of a tough question and definitely a little tricky, but these are the questions I want you to get used to seeing and used to getting it wrong so you can learn from them for next time. But good job in picking nephrogenic diabetes insipidus, and that would have been the answer for most situations. Just this unique situation, because the serum sodium is low, that is a trap here. Don't feel bad. Definitely a trick question, but I wanted to make sure we talked about that concept, and I'm hoping that you guys really learn from that.